It is important for surgical patients in rural and remote areas to get back to work as soon as possible. Minimally invasive surgeries, like laparoscopy surgeries, make this possible. However, the high cost, the logistic nightmare of providing gases for both anesthesia and surgery, and finding as an anesthesiologist in rural areas means that laparoscopy surgeries are not available to 90% of the rural population who need them. The most important step to provide laparoscopic surgeries in rural areas starts with making laparoscopic surgeries possible under the easily available and low-cost spinal anesthesia. The gas insufflation-less laparoscopic surgeries, GILLS in short, makes this possible under spinal anesthesia. Laparoscopic surgeries are carried out by passing instruments through small incisions and looking inside the abdomen using a telescope and camera. The insufflation of gas distances the abdomen and makes space for using the instruments to carry out the surgeries. The gas also pushes away the intestines that come in the way. Unfortunately, the gas increases the abdominal pressure and also gets absorbed. These cause physiological changes that calls for experienced anesthesiologists to manage. The GILLS surgeries are performed using special equipment to lift the abdominal wall so that necessary space could be created to carry out the surgical procedures. And the positioning of the patient uses gravity to move the intestines away from the surgical field. The laparoscopic surgeries became popular in the late 80s, but by early 90s, several attempts were made to produce gasless laparoscopic surgical equipment. This is to avoid the physiological changes that occur with gases, especially in patients with comorbidities and those who need prolonged laparoscopic surgery. However, poor exposure and the problem of tenting with the early devices, even with the motorized devices, made it difficult to perform these surgeries. Hence, most of the publications which are there are from single centers using their own equipment. Dr. Hashimoto is considered the father of gasless laparoscopy surgeries, and the various devices that you can see in the background illustrates the problem of stenting and poor exposure, despite the various motorized capabilities.
The first device which sort of gave an exposure was similar to the conventional laparoscopy surgery, the abdominal lift device by Dr. Daniel Kruszinski. There were modifications of this in the second generation equipment and so on. And we got this device made, which gave us almost as good an exposure, especially the BMI less than 28. And it is very easy to use in remote areas.
It took about a decade to develop a device with reasonable exposure. In Germany, it was especially promoted to prevent post-operative additions, which occur because use of dry gas, which is also cause hypothermia. And these prevention of additions and the physiological advantages were used to advantage in gasless surgeries. In recent times, the rural surgeons have been using gasless surgeries, working on modification with the primary purpose of taking laparoscopic surgeries to rural and remote areas. It has the advantage of easier learning curve compared to the conventional surgeries. The possibility of using techniques which they're familiar with for open surgeries, and also using some of the open surgical instruments, in addition to the capability of performing them under the easily available spinal anesthesia. It also has other advantages. There's less pain and less infection. The short hospital stay means that Most surgeries are possible with limited resources in rural areas, and also allows visiting teams to perform laparoscopic surgeries in rural areas. The importance of minimally invasive surgery was so much in rural areas that we performed diagnostic laparoscopies using the cystoscope.
Diagnostic laparoscopy with cystoscope. The positioning of the patient is guided by the possible diagnosis. In this patient with low esophageal cancer, the patient is placed supine with the legs separated and the head end slightly elevated. The umbilicus is held up with a towel clip and a small incision is made below the umbilicus. The taut rectus is divided with the electrocautery and a small opening is made into the peritoneal cavity. The cystoscope is introduced through the opening and the interiors could be visualized. The blood pressure cuff could be used for creating pneumoperitoneum if an insufflator is not available. Biopsies could be taken using the flexible biopsy forceps. In liver biopsies, it's better than even the biopsy gun because only superficial tissues are biopsied, and cauterization of bleeding point could be carried out using a locally made electrocauterization probe, similar to the Bugbee electrode. In case of evaluation of infertility, it's a very useful tool. The patency of the tubes could be studied by injecting methylene blue dye.
The cystoscope was also used for carrying out small elective procedures like appendicectomies. You might wonder why not make traditional laparoscopic surgeries less expensive. We did try. We used ether and EMO machine to reduce the cost of anesthesia, and then air from dental compressor for insufflation. However, these are not the ideal procedures. The stand laparoscopic positioner was developed to use in rural areas. It's easy to use, and the exposure offered it is not inferior to the conventional laparoscopic surgeries. In fact, a randomized control trial carried out in Maulana Azad Medical College showed that for BMI less than 28, there's no difference. In fact, the GILLS surgeries were a little quicker. What are the impact of these gasless surgeries? Over 1,500 laparoscopic surgeries were carried out in rural and remote areas under spinal anesthesia, and several rural surgeons were able to learn this technique. And many are still continuing to do these surgeries on their own. They do surgeries like cholecystectomies, appendicectomies, hysterectomies, ovarian cystectomies, and most of the pelvic surgeries are carried out using GILLS. A formal training program was developed by the University of Leeds that includes an innovative proctorship program. A second generation of device was also developed by the Leeds team using frugal participatory developmental process. Noel will talk a little more about this. Hence, the GILLS or gasless laparoscopic surgery is an ideal procedure to take laparoscopic surgery of minimally